Into susception. What is into susception? Telescoping of one part of the bowel into another. Telescoping of one part of the bowel into another is into susception. So in this, what happens is one part of the bowel goes into another bowel. So there are few terminologies which we have to know here. There is something called into susception, and there is something called into susceptum. Telescoping of one part of the bowel into another is into susception. And in into susception, we have to know these terminologies. There is something called into susception, and there is something called into susceptum. The into susception is the bowel which receives another bowel. The bowel which is receiving another bowel is called into susception, and the part of the bowel which goes in, the part of the bowel which goes into another bowel, that part is called into susceptum. So there is into susception and there is into susceptum. Now, this into susception can happen in an infant. This can be seen in an infant age group. This can be seen in adults also. Into susception can be seen in a pediatric, can be seen in a adult also. Now, more commonly, it is seen in a pediatric age group. More commonly, this into susception is seen in a pediatric age group, and this pediatric age group, most of the time, these pediatric patients are of the age of 6 to 9 months. And very, very important point to note, at this age group, why one part of the bowel goes into another bowel, why one bowel is going into another bowel, it is not known. Why one part of the bowel is going into another bowel, it is not known. But once the intersusception happens after this age group, once intersusception happens after this age group, there is some lead point is there in intersusception. There is some lead point is there. Lead point is the point which is an inviting point for the another bowel to come in. So in case of a age group of 6 to 9 months, where it is most of the time seen, it is still not known why one bowel goes into another bowel, right? So if you are asked what is the most common cause of intersusception, it is idiopathic, because it is not known that why one part of the bowel is going to another. But since, important point, since this This age group is corresponding to the timing of weaning. So it is presumed to be due to, important point, hypertrophy of pairs patches. It is presumed to be due to hypertrophy of pairs patches, but it is still not clear. But after this age group, there is some lead point important to know in intussuscipion checked in exam. So what are the various lead points which can be the inviting point for a intussusception to happen? The various lead points are polyp. Various lead points are polyp, lipoma, Peutz. You should know these lead points. Peutz, Jaeger syndrome, Peutz-Jaeger syndrome, Enoch, Scollin purpura, Enoch, Scollin purpura, lymphoma, diarrheal diseases, and even malignancy can lead to intussusception. But this lead points important to note is there in the intussuscipion. And the most common type of intussusception, a question asked, is ileocolic. The most common type of intussusception is ileocolic, and the least common type is retrograde, followed by multiple. In intussusception, this is another important point which we should know. In intussusception, the proximal bowel usually goes into a distal bowel. In intussusception, it is usually the proximal bowel which goes into the another bowel, the distal bowel. Okay, so most common type of intussusception is ileocolic. Now, what is the most common presentation? This presentation of intussusception is quite classical. So you will be provided in the clinical profile such kind of a presentation. So if such kind of presentation is there, one should suspect intussusception. So what is the classical presentation here is? The most common and characteristic presentation, of intussusception is waxing and waning type of pain abdomen. Now, what is this waxing and waning type of pain abdomen means? These patients will come to you with a classical presentation. The parents of these patients will tell you that suddenly this kid start crying, and when he cries, he pulls his leg towards the abdomen, and suddenly he's all right. Out of nowhere, he suddenly starts crying and pulls his leg towards the abdomen, because 6 to 9 month patient will not be able to say what is happening. So they say by crying. So they start crying, he starts crying suddenly and pulls his leg towards the abdomen, and suddenly he's all right. So if this kind of presentation is there, one should suspect intussusception. And in these patients, there can be associated vomiting, and very important to note, there can also be associated This red current jelly stool is a very important point. They can have a red current jelly stool also. And another very important point in these patients is when you do examination of these patients, on examination of these patients, during the time of the pain, this finding is only there when the pain is happening. Otherwise, this finding is not there. What is that finding? You will find a sausage-shaped lump. You will find a sausage-shaped lump. Sausage-shaped, this sausage shape is important. Sausage-shaped lump in right hypochondrium. Sausage-shaped lump in right hypochondrium with empty right iliac fossa. Presence of a sausage-shaped lump in right hypochondrium with empty right iliac fossa is called sign of D dance. Presence of a sausage-shaped lump in the right hypochondrium with empty right iliac fossa is called sign of D dance. If this is provided, it is a classical sign seen in intussusception only. And the investigation of choice. Again, a question asked. Investigation of choice for intussusception is ultrasound. Important. Investigation of choice for intussusception is ultrasound, and on ultrasound of a patient of intussusception, important to note, one gets a donut sign or target sign or a pseudo kidney sign. One gets a target sign, pseudo kidney sign, or a donut sign, which is also called bull's eye sign. These are all same signs. So, and if by any chance you do barium enema in these patients, if by any chance you do a barium enema in these patients, you will get a claw sign. One may get a claw sign also, or a coiled spring sign also. One may get a claw sign or a coiled spring sign on barium enema. Now, the first line of management, very important point, the first line of management in intussusception is therapeutic, hydrostatic enema. Therapeutic, hydrostatic enema. What is this hydrostatic enema? In this type of enema, you are supposed to give enema fluid from height. Height doesn't mean that you will climb on second floor and give. Height is from the 60 centimeter from the heart level of the patient. Height means you are supposed to give this enema fluid from a 60 centimeter from the heart level of. Now, what they ask in your exam, that what enema fluid you use for this hydrostatic enema. The enema fluid which you use, we can use air, we can use water, and we can also use diluted barium. We can use air, we can use water, we can also use diluted barium, and commonly checked again in exam, we use air. Commonly we use air. So this is the first line of management. An important point further to note, most of the time, this treatment is successful also. Most of the time, this treatment in intussusception is successful also. But sometimes it may not be successful. Once it is not successful, we are then supposed to do surgery. And this is how a claw sign look like. Claw, right? So it is on barium minimum. You are seeing a claw, right? बीच बीच में होता रहता है. 60 centimeter from the heart level of the patient. And if it is not successful, then only we are supposed to do surgery. In intussusception. So these are the things we need to know in intussusception. Then comes meconium ileus. Now, what is this meconium ileus? Meconium ileus is a GI manifestation of cystic fibrosis. Meconium ileus is a GI manifestation of cystic fibrosis. Let's understand this problem. It's a GI manifestation of cystic fibrosis. I hope you know what happens in cystic fibrosis. In cystic fibrosis, yes, in cystic fibrosis, all the secretions of the body becomes viscid, thick. So is the meconium. So what happens is, because of cystic fibrosis, the meconium inside the bowel becomes very thick. Once it becomes very thick, it gets clogged at a ileocecal junction, which is the second narrowest point of GIT after cricopharyngeal sphincter, right? So this thick meconium gets clogged at ileocecal junction, right? And once this meconium gets clogged, this meconium gets clogged at ileocecal junction. If this meconium gets clogged quite early in the intrauterine life of will distend, and by the time this newborn takes birth, the bowel already has perforated, because this clogging happened quite early in the intrauterine life. So when this newborn takes birth, that time there is only obstruction. So it is quite possible that because of this cystic fibrosis, the newborn can have a meconium, peritonitis at the time of birth, can have meconium ileus also. So at birth, the newborn can have obstruction because of this cystic fibrosis manifestation, and at birth, the newborn can have peritonitis also. How will this newborn is going to present to us? The newborn is going to present to us in both these conditions with non-passage of meconium. Will present to us with a non-passage of meconium. There will be vomiting and there will be distension of the abdomen also. And the newborn will be seen crying inconsolably. The newborn will be crying inconsolably because of the pain. So on the basis of this, you can appreciate we will not be able to differentiate whether it's a ileus or peritonitis, because both obstruction, by now we have understood that both obstruction and peritonitis have a similar symptoms. It is only on examination we come to know that whether the patient is obstruction or peritonitis. So on examination of a patient of meconium ileus, before we talk about ileus, on examination of a patient of peritonitis, meconium peritonitis, what will be the finding? Can you tell me? Tenderness, guarding, and rigidity. Agree? And in a patient of meconium ileus, very, very important, quite commonly checked, on examination, you will get a doughy abdomen. Like a dough, right? What is dough? Atta, gunda atta, right? So you get a doughy abdomen feel when you do the examination. Okay, very important. And we all know by now that in any patient of obstruction, we are supposed to do what first investigation? First investigation. We do X-ray abdomen in any patient of obstruction. We know that by now. So in X-ray abdomen of a patient of meconium ileus, very important point. The classical appearance is there, which is called a soap bubble appearance. And very, very important point to note, in these patients, though there is an obstruction, air fluid levels are classically absent. Why air fluid levels are absent in these patients? Because there is no fluid. Everything there inside is a paste, thick. So there is nothing which is going to settle and form a air fluid level. So air fluid levels here will be absent. While in case of meconium peritonitis, if you do X-ray abdomen, you will get intra-abdominal calcification. The meconium which leaks out from the hole in the bowel. Because of the obstruction, the perforation happens subsequently and the meconium leaks out from the site of the perforation, and this meconium inside the intrauterine life gets calcified, and when you do X-ray, you will get an intra-abdominal calcification. Right? Now comes the management. In management of a patient of meconium ileus, the first line management is therapeutic, hygroscopic. Please note the difference. Hygroscopic here. Hygroscopic enema. What does this hygroscopic enema means? In this condition, the problem is not any mechanical thing. The problem itself is a thick paste-like meconium. So if we make this thick paste into a fluid kind of thing, it may start flowing. So what we give, we give a hygroscopic agent as an enema fluid. What this hygroscopic agent does, when this hygroscopic agent reaches the ileum, the ileocecal region, it creates an osmotic gradient and it pulls the fluid from the cellular compartment of the ileum into the intraluminal compartment. And when the fluid comes from the cellular compartment to the intraluminal compartment, this thick paste becomes less viscous and starts flowing. So what is important for us to know is what hygroscopic agent is given. The hygroscopic agent which is given is N-acetylcysteine. The hygroscopic agent which we give is N-acetylcysteine. And if this treatment fails, which can fail, if this treatment fails, then we are supposed to do surgery. But please be very, very careful. In a patient with meconium peritonitis, we directly go for surgery. There is no role of therapeutic hygroscopic enema. We directly go for surgery. And what that surgery is, just need to know the name. Bishop-Koop operation. What that surgery is? Bishop-Koop's operation. Right? So this is what we need to know in meconium ileus. Then comes Meckel's diverticulum. Meckel's diverticulum, very important point, is the most common true diverticulum of not only ileum but also whole GIT. Very important point. This is the most common true diverticulum of not only ileum but also GIT. And this is, you all must be aware, is a remnant of vitelo-intestinal duct. This is the remnant of vitelo-intestinal duct, right? And this Meckel's diverticulum, very important, is always on the anti-mesenteric border of ileum. This is always on the anti-mesenteric border of ileum. And in this, there is a rule of two. What is the rule of two? In 2% of the patient, it is seen. It is present in 2% of the population. It is 2% of the time symptomatic. It is 2% of the time symptomatic. It is 2 feet from ileocecal junction. It is 2 inches long. It is 2 centimeter wide. It has 2 types of atrophic tissues. Most common ectopic or heteropic tissue checked again in exam here is gastric mucosa. If not, then pancreatic tissue. It is 2 times more common in males. It usually presents at 2 years of age group. These are the various twos here. So if I ask you now, what is the most common presentation of Meckel's diverticulum? 2% of the time it is symptomatic. So that means 98% of the time. So most common presentation is asymptomatic, incidentally found. Incidentally found का क्या मतलब होता है? You are doing surgery for some other reason and you came across Meckel's. This is how we most of the time we come across. And important to note, when it presents with symptoms, it actually presents because of its complications. Right? So most common symptom, if asked, is actually the most common complication of Meckel's also. And what is that? That is bleeding. And very, very important point to note further, Meckel's diverticulum is a most common cause of melena in pediatric age group. It's a most common cause of melena in pediatric age group. It can also present because of its inflammation, which is called Meckel's diverticulitis. It can also present with obstruction, features of obstruction, and it can also lead to volvulus. Now, what is the investigation of choice for Meckel's diverticulum? ये complications ही symptoms भी हो सकते हैं. It presents these are the complications and these can be the symptoms also. Meckel's diverticulum के symptoms the patient can present. Obstruction के symptoms the patient can present. Volvulus के symptoms the patient can present. Investigation of choice for Meckel's diverticulum, very commonly asked question, is technetium 99 labeled RBC scan, which is also called per-techne or Meckel's scan, which is also called per-techne or Meckel's scan. Now comes a very important question. Most of the time, we come across Meckel's when we are doing surgery for some other reason, incidentally. So when we come across Meckel's incidentally, which most of the time we come across, what to do about Meckel's? Should we remove it or should we leave it? छोड़ दिया जाए, निकाल दिया जाए, or it depends on your mood. It, as per the latest guideline now, it depends. It depends on what? If the patient is young, if the Meckel's has a narrow base, if the Meckel's has attachment, it is attached to some structure physically, not emotionally. If it has a induration at base, if any of these are there, we should remove metals. Otherwise, we can leave it. Now, how will you remove metals? There are two ways of removing it. One is this. One is this. This is called wedge resection. This is called wedge resection. And another is this. Removing this segment and doing the anastomosis. This is called segmental resection and anastomosis. Out of these two ways of removing metals, you should know preferred is wedge resection. Preferred is wedge resection, right? So these are the things we should know in metals. Then comes mesenteric ischemia. Now, in mesenteric ischemia, there can be acute mesenteric ischemia. There can be a chronic mesenteric ischemia. Let us first talk about chronic mesenteric ischemia. The most common cause of chronic mesenteric ischemia is atherosclerosis. Most common vessel involved here is superior mesenteric artery. Most common vessel involved here is superior mesenteric artery. Then, how does these patients are going to present? Most common age of presentation, more than 50 years. It is more common in males than in females. पता नहीं तुम लोग को ये कंफ्यूजन होता नहीं होता, पर मुझे बहुत होता है। ये मेल में ये है या मेल में ये है, बहुत कंफ्यूजन होता था। कई बार मैं लिख देता हूँ यूँ और बोलता हूँ फिर मेरे को नहीं ये नहीं शादी है, क्या निकाले? पब्लिकली नहीं बता सकते तो रहने दो। मोस्ट कॉमन एंड कैरेक्टरिस्टिक presentation, most common and characteristic presentation. जैसे एक बार हमारे साथ हुआ, my guide and I was doing surgery. तो हमारा मेरे जो guide थे, he was a very good surgeon. I was very lucky to get such a kind of mentor, and he was a polished guy. Polished guy to the, मतलब he was from a Royal College of Surgeons, England, and he has done his most of the training from there, and he only used to talk in English, and that too British English, accent वाला. तो हम राउंड दिलाते थे तो इंग्लिश में राउंड होना था. तो हमारे साथ एक जेआर था बिहार से. तो आई वॉज इन सेकेंड ईयर, तो फर्स्ट ईयर पीजी आया, तो फर्स्ट ईयर पीजी राउंड दिलाना शुरू कर रहा था. तो हमने उसे बता दिया था कि भैया इंग्लिश में बात करनी है, हिंदी नहीं चलेगी. तो ही वाज थोड़ा सा प्रॉब्लम थी इंग्लिश में, तो ही वाज ट्राइंग. So sir told him, no, actually you should talk in front of the patient in English because patient should not understand what is. तो मतलब बिल्कुल वो एक्सेंट वाला. तो सर समझा रहे थे सर कि इंग्लिश में बात करनी चाहिए, क्योंकि पेशेंट के सामने अगर हिंदी में बात करोगे तो पेशेंट में फाइंड इट उसको अपनी प्रॉब्लम समझ और वो ग्रेव समझ लेगा. बट ऑल दैट इतनी देर में ये जेआर आता है, मतलब बिल्कुल माहौल इंग्लिश वाला, बिल्कुल वैसा सोफिस्टिकेटेड माहौल, ऐसा लग रहा है यूके में राउंड चल रहा है. अचानक से जेआर आता है. क्या हुआ कि सर उस पेशेंट को ना पानी बंद हो गया है, मतलब उसकी आईवी लाइन चल रही थी, उसका पानी बंद हो गया, पानी नहीं लग रहा है. पानी बंद हो गया. So what this guy is saying, sir, we will settle. Don't worry about it. It was very hilarious actually. वो उसने जिस तरह से बोला और वो जो माहौल में थे हम, वो माहौल को एकदम से उसने ऐसे चेंज कर दिया कि जैसे हम बिल्कुल बिहार के किसी गांव में आ गए. Most common and characteristic presentation of chronic mesenteric ischemia is postprandial pain abdomen. Very classical. These patients, after having meal, they start having pain in the umbilical region, and this pain always happens after taking meal. So this is also called intestinal angina or intestinal claudication. It is called intestinal angina or intestinal claudication. And very important point to note further in this is, since this patient always have pain after taking meals, they start having a fear of food, and that fear of food is called cytophobia. There was a question asked, in which of the following condition you get a cytophobia? So in chronic mesenteric ischemia, you may get a cytophobia also. And investigation of choice for this condition is CT angio. Investigation of choice is CT angio, and the gold standard is conventional angiography. And the treatment of choice for this condition now is balloon angioplasty. Treatment of choice for this condition is balloon angioplasty. Then comes एंड अब सर की बात हुई है तो मेरे को एक और बात याद आई. सर इस तरह से सरकास्टिक इंग्लिश बोलते थे कि आपको लगता था, मतलब आपकी बेइज्जती हो रही है पर आपको अच्छा लगता था कि सर थोड़ा और बोलो, अच्छा लग रहा है. मतलब बेइज्जती कर रहे हैं आपकी, बट आपको लगता था और करो सर, अच्छा लग रहा है, इतनी अच्छी इंग्लिश में बोल रहे हो तो अच्छा ही बोल रहे हो. एक्यूट mesenteric ischemia. There can be various causes of acute mesenteric ischemia. The various important causes of acute mesenteric ischemia are acute change in thrombus, emboli, and hemorrhagic shock. These are the three important causes of acute mesenteric ischemia, and out of these three important causes, checked many times in exam, the most common cause is emboli, and the most common source of this emboli, is heart, and in heart it is atrial fibrillation. Most common source of this emboli is heart, and in heart it is atrial fibrillation. And most common vessel involved here also is superior mesenteric artery. And here also there is a classical presentation, most common and characteristic. And this is the earliest presentation also. And what is that most common and characteristic presentation here? Sudden onset, severe abdominal pain with paucity of abdominal signs. Sudden onset, severe abdominal pain with, what does this mean? You know, this will be a clinical profile to you. Again, you have to understand this clinical profile. You will be provided that the patient is a patient of heart disease, some heart disease, having an irregular heart rate. And then it will be told to you, coming to you with a severe abdominal pain, and there is, on examination, there is no finding. This is a classical presentation of these patients. You will presume, if you are not suspicious, you will presume that this patient is malignant. And it is this time, if you diagnose this condition, you can avoid gangrene of the bowel. Because this is the earliest thing which happens. After that, the features of gangrene will come up. So, patient will come to the severe abdominal pain. When you examine abdomen, there is no finding. And you will presume that the patient is malignant. Later on, the patient develops distension. Important to note, black, current, jelly stool, tenderness, rebound tenderness, guarding, and rigidity. So these are the late signs, and by that time these signs happens, the gangrene of the bowel has already happened. So it is at this time, if you are suspicious, then only you can prevent gangrene of the bowel. ऐसे मत करो यार. Now, the earliest part of the bowel, again a question asked, earliest part of the bowel which gets gangrenous here, checked again in exam, is splenic flexure. And in these patients, in lab parameters, again these lab parameters are very important for us in our clinical question. TLC count will be high. There will be serum lactate of the patient also will be high. LDH of the patient is also high, and the D dimer also of the patient are raised. And if you do X-ray abdomen in these patients, again important, in X-ray abdomen of these patients, you will get a thumb printing sign. Investigation of choice here also is CT angio. Gold standard here also is conventional angio. And very, very important, this can be a question again in your exam and you have to be very careful. If in any such patient, if comes to you, the immediate next step in any patient of acute mesenteric ischemia is IV heparin. Immediately, we are supposed to start, once we diagnose acute mesenteric ischemia, IV heparin. We have to stabilize the clot. For that, we have to immediately start IV heparin. Now, after this, if the patient comes to us in early stage, or if the patient comes to us in late stage. If the patient comes to us in early stage, we should try to salvage the bowel. We should try to prevent the gangrene of the bowel by doing embolectomy. By doing embolectomy, there are two types of embolectomies. Open embolectomy and Fogarty's embolectomy. Open embolectomy and Fogarty's embolectomy. Preferred is Fogarty's embolectomy. Now, what is this Fogarty's? Fogarty's is a catheter. Checked again in exam. Fogarty's is a catheter used to remove embolus from a vessel. Fogarty's is a catheter used to remove embolus from a vessel. But if the patient comes to us in late stage, we are left with no choice but to do exploratory laparotomy with resection of gangrenous, bowel. And one should also note here that acute mesenteric ischemia is the only condition where there is a role of second look laparotomy. Acute mesenteric ischemia, they can ask you in which of the following condition we do a second look laparotomy. Acute mesenteric ischemia is the only condition where we do a second look laparotomy. So these are the things we need to know about acute mesenteric ischemia. Then comes appendix. Now, in appendix, you all know that this is cecum and this is how the appendix is. Now, in appendix, very important, base of the appendix is always fixed. This is the base of the appendix and it is always fixed. But this tip of the appendix can be at various positions. The tip of the appendix can be at various positions, and the most common location of the tip of appendix, a question very commonly asked, is retrocecal, followed by pelvic. And the least common position of appendix is post-ileal. Now, one thing very important for you to know, this can be a potential question in a clinical pattern exam, and this very commonly happens in our day-to-day surgical practice also. We know that the tip of the appendix can have various positions. Base of the appendix is always fixed. We know this. And when we do appendectomy, listen to this point carefully. When we do appendectomy, we are supposed to locate the tip of appendix. We have to find out the tip of appendix and hold the tip of appendix and then do the appendectomy. Now, sometimes it is difficult to locate the tip of the appendix during surgery. So, when we are doing surgery, when you do your post-graduation, you should be doing your post-graduation. When you do your post-graduation surgery, the first emergency procedure you get to do will be appendix. And appendix करने के बाद आपको ऐसा लगता है कि बाकी सब लोग कीड़े मकोड़े. You feel you are on top of the world. After doing any surgery, you feel that way. Actually, आपको सब लगता है कि कीड़े मकोड़े. और सर्जरी में कोई कॉम्प्लिकेशन हो जाए, सर्जरी अगर अच्छी करो तो आपको बहुत हाई फील होता है, बहुत हाई वाली फीलिंग आती है, एड्रेनलिन रश अच्छा वाला होता है, और आपको ऐसा लगता है कि आप ही आपको नहीं सारा भगवान है. एंड जब आप कोई कॉम्प्लिकेशन कर देते हो, known complication of any procedure can happen. We are supposed to locate the tip of the appendix, or sometimes it is difficult to locate the tip of appendix. So once you find it difficult to find a tip, we know that the base is fixed. So we should always try to reach to the base. Now, how will you reach to the base? You are supposed to follow the cecum, and on the colonic wall, this is important, there are 3 band-like structures, and these 3 band-like structures are called tinea coli. There are 3 band-like structures there on the colon. Wherever these 3 band-like structures are converging, that is the base of appendix. So, if you don't find a tip of the appendix, you are supposed to locate the base. And how will you locate the base? You should follow tinea coli on colon. Wherever they are converging, that is the base of the appendix. Now, most common location of the appendix is retrocecal followed by pelvic. Now, appendicitis is the most common surgical emergency. Appendicitis is the most common surgical emergency and the most common site of appendicular perforation. Very commonly asked question is tip of appendix. Most common site of appendicular perforation is the tip of appendix. Now, in appendicitis, now can you tell me what is the most common cause of acute appendicitis? The most common cause of acute appendicitis is fecal obstruction. Most common cause of acute appendicitis is fecal obstruction. If not there in your choice, very commonly these questions are asked: lymphoid hyperplasia. And acute appendicitis can also be because of worm infestation. Which worm? It is very good. Pinworm. What is pinworm? Enterobius vermicularis. Enterobius vermicularis. And the most common organism involved in acute appendicitis, again a very commonly asked question, is bacteroids. If not in your choice, then E. coli. Now comes, how does a patient of acute appendicitis presents? There are typical symptoms, there are atypical symptoms. There are typical symptoms and there are atypical symptoms. Now, can you tell me what is the most common typical symptom of acute appendicitis? Pain in the generalized pain that get localized. Very good. It is most common typical symptom of acute appendicitis, migratory pain. And please be very careful. Write down in capital letters again that most common atypical symptom is pain in right iliac fossa. So pain starting in right iliac fossa is not a typical symptom of acute appendicitis, mind it. It is a pain starting in the umbilical region, then shifting to right iliac fossa, which is called migratory pain, is the typical symptom of acute appendicitis, and that's the most common also. Patient can also present to us with loss of appetite, not weight loss this time. Loss of appetite, patient present to us with loss of appetite, and patient can also present to us with nausea and vomiting. There can also be fever. These are the typical symptoms of acute appendicitis. And very, very important point further. Check again. This fever in acute appendicitis is a low-grade fever. A patient having a high-grade fever is against the diagnosis of acute appendicitis minded. Patient having a high-grade fever is against the diagnosis of a acute appendicitis. Now, in atypical symptoms, pain in right iliac fossa starting is an atypical symptom. Then, other atypical symptom is tenesmus. What is tenesmus? What is tenesmus? Feeling of? Very good. Tenesmus is feeling of incomplete evacuation. Patient can also come to us with diarrhea, or increased frequency of micturition. And these atypical symptoms are more common with pelvic appendix. Pelvic appendix. Now, on examination of these patients, pelvic appendix. On examination of these patients, you will find tenderness in right iliac fossa. There can be rebound tenderness also. The rebound tenderness in right iliac fossa is also called Bloomberg sign. It is called Bloomberg sign. Then there can be pointing sign also. There are few signs we have to know here. Pointing sign. Say you should not point your finger on anyone, especially your middle finger. These patients of acute appendicitis will come to you pointing their finger, obviously not a middle finger, pointing their finger towards the pain, saying that my pain started here and now it is here. So what does that mean? It means that the pain is so localized. The pain is so localized that patient can even point pain with finger. Otherwise, in vague pains, we will hand like this. So this is called pointing sign, which suggests that the pain in acute appendicitis is so localized. Then there can be another sign called Rossing sign. What is Rossing sign? Palpation at right iliac fossa. Sorry, palpation at left iliac fossa, leading to pain in right iliac fossa. Then there can also be a sign called Ko-Swas sign, which is seen in important retrocecal appendix. What is Ko-Swas sign? Hyperextension of hip, leading to pain in right iliac fossa. Hyperextension of hip leading to pain in right iliac fossa. Then there can also be another sign called obturator sign, seen in pelvic appendix. Important. What is obturator sign? Flexion and internal rotation of hip leading to pain in hypogastrium. Flexion and internal rotation of hip leading to pain in hypogastrium is obturator sign. Then there can also be a sign called Dunphy sign. चेक भी करते हैं. Dunphy sign is coughing and crying leading to pain in right iliac fossa. एक और बात, देखते हैं या नहीं देखते हैं, एग्जाम में पूछते हैं, है ना? तो हमें तो मुद्दे पे रहना ना, पॉइंट वहां है. Dunphy sign. Then there is a sign called 10-horn sign. What is 10-horn sign? Gentle traction of right spermatic cord. Gentle traction of right spermatic cord leading to pain in right iliac fossa of the individual sitting next to the patient of appendicitis. Pain in right iliac fossa of the patient. And how do we diagnose acute appendicitis? The diagnosis of acute appendicitis is clinical. We diagnose appendicitis on the basis of a clinical score. M stands for migratory pain. A stands for anorexia. N stands for nausea, vomiting. T stands for tenderness in right iliac fossa. R stands for rebound tenderness. E stands for elevated temperature. L stands for leukocytosis. And S stands for shift to left. Means more of polymorphs. And very important point in this to notice, out of all these points, leukocytosis and tenderness in right iliac fossa got 2 points. They will ask you that which of the following parameter got 2 points in Alvado score. Tenderness in leukocytosis are the 2 things which got 2 points. Rest all got 1 point. So that means this is a score out of 10. Right? Anybody having a score of more than or equal to 7 is considered to have acute appendicitis. Anybody having a score of less than 5 is considered to have something else. It rules out acute appendicitis. A score of less than 5 rules out acute appendicitis. Important. Investigation of choice, if asked, it is CT scan, but we rarely do CT scan for diagnosing acute appendicitis. We use this score. In pediatric patient and in pregnant females, the investigation of choice is ultrasound. In pediatric patient and pregnant female, it is ultrasound. Now, is it an acute infective GI condition? So what should be the first line of management? And after this, the treatment of acute appendicitis is appendectomy. There are two ways of doing appendectomy: open appendectomy and laparoscopic appendectomy. We can do appendectomy by open technique. We can also do it by laparoscopy. Now, preferred is laparoscopy. Now, preferred is laparoscopy. In open appendectomy, these are the points important. In open appendectomy, we have two types of incisions checked in exam: muscle splitting incision. It is splitting, not spitting. Muscle splitting incision and muscle cutting incision. Now, in muscle cutting incision, ये कवि किस मसल की बात कर रहा है? In muscle cutting incision, we are talking about internal oblique and transversus abdominis muscle. Checked in exam. Which muscle is cut? Internal oblique and transversus abdominis muscle. Muscle cutting incision is also called Rutherford-Morrison incision. Muscle splitting incision are MacArthur, or which is also called gridiron, and Lance or Rocky Davis incision. Now, important point in this to note is that be it a muscle cutting, important point in this to notice, be it a muscle cutting or muscle splitting incision, all these incisions are centered on, both these incisions, be it muscle cutting or muscle splitting, are centered on McBurney's point. Now, what is this McBurney's point? This is anterior superior iliac spine, and if this is umbilicus, anterior superior iliac spine and umbilicus. So we join this umbilicus with anterior superior iliac spine with an imaginary line and divide this line into 3 equal halves. We divide this line into 3 equal halves, and this point, which is the junction of lateral 1/3 and medial 2/3 of this line, is called McBurney's point. And one more thing which is important for us to know, that in a Rutherford-Morrison incision, a muscle cutting incision, sometime there can be an injury to the nerve, which can lead to inguinal hernia also. Which nerve injury can lead to inguinal hernia after appendectomy? A potential question. Ilio-hypogastric inguinal hernia. IH. Ilio-hypogastric nerve injury leads to inguinal hernia after appendectomy. Okay, now another very important point. We most of the time listen to this clinical part carefully. I already told you when we don't find a tip of appendix, we should search for the base. And how to search for the base, we know now. We should also know that most of the time we make a diagnosis of acute appendicitis on the basis of this clinical score, that is Alvado score. So when we go ahead for appendectomy with a Alvado score, if we don't find appendix inflamed, what to do? Very commonly asked thing, and this is very commonly happens in our day-to-day practice also. We went ahead with the diagnosis of acute appendicitis on the basis of a clinical score, but when we did open or laparoscopy, whatever way appendectomy we are doing, we didn't find, imagine, appendix inflamed. निकाल देंगे जब तो क्या निकाल रहे हैं? They have to be very specific. क्या निकाल रहे हो भाई? ठीक वैसे नहीं रहे, पता नहीं क्या निकाल रहे. Okay, now in this scenario, first of all, listen to this very important point. If you don't find appendix inflamed, you should search for the other pathology. You have to look for the other pathology. Search for the proximal 50 centimeter of the ileum, because there can be Meckel's diverticulum there, which can be the reason for this pain in the right leg fossa. So, if appendix is not found inflamed on table in surgery, we should search for the other pathology. Listen to this part very carefully. If the other pathology is found, treat that other pathology, leave appendix. Appendix की गलती नहीं है. It is the other pathology which was a culprit. So treat that other pathology, leave appendix. Okay? But if the appendix is not inflamed and the other pathology is also not found, then you should remove the appendix, as he rightly said, nikal denge. Appendix nikal denge. Right? So then we should remove appendix, but subject to condition, the other pathology not found. Very important, they can ask this question to you. And the most common complication of appendectomy is wound infection. And the most common long-term complication is post-operative adhesive obstruction. Post-operative adhesive obstruction. Right? Now, I just told you in our discussion that after this, in acute appendicitis, we will proceed to appendectomy. This is what we just talked about. But listen to this part very carefully. But if in any patient who comes to us with clinical signs and symptoms of acute appendicitis, if on examination, we find a lump in the right iliac fossa, this is called appendicular mass or appendicular lump. If we find a appendicular mass or lump in the right iliac fossa, this is an absolute contraindication for appendectomy. Whenever we find a mass in the right iliac fossa in a patient who comes to us with signs and symptoms of acute appendicitis, we should not do appendectomy. Important. And what we will do then? We will continue with this treatment. And this treatment continuation here is called Ochsner-Sharon regime. This continuation of this conservative treatment, which he has always started, is called Ochsner-Sharon regime, and we will observe this patient now with this treatment continuing every 4 hourly. Important point. Please note this point. This is important. They can frame a clinical question on this. We should know that in appendicular mass, we will not do appendectomy. However, we will follow the patient with a regime, this treatment regime, and observe this patient 4 hourly for what? We will observe the pulse rate of the patient. We will observe temperature of this patient. We will observe the size of this lump of the patient. Now, if these 3 parameters on 4 hourly charting are decreasing, what does it suggest? Patient is improving, responding to the treatment. It suggests patient is responding to the treatment. So once the patient improves, it was earlier said that this patient should be offered interval appendectomy after 6 weeks. Interval appendectomy after 6 weeks. But now they say no interval appendectomy. Now they say interval appendectomy after 6 weeks should only be done if the patient is pediatric, if the patient has a recurrent appendicitis history in past, then only we should do a interval appendectomy after 6 weeks. Otherwise, you will discharge the patient and tell him to not to come back again. Only in this scenario, after 6 weeks. Why are we not doing appendectomy? Not the reason is not that. Earlier also patient responded, but we were doing it. What they found out that once this patient improves, only 20% of these patients in their lifetime ever develop a repeat attack. So there is no point removing appendix in 80% actually. So now they say no interval, only if the patient has a recurrent attack or pediatric, then only. Samjhe? Right? Now, what if the patient, these parameters are increasing? What if these parameters are increasing? Means patient is not responding. So these parameter increase is suggesting that the patient is developing a appendicular abscess. Increase in these parameters in 4 hourly assessment, increase in these parameters in 4 hourly assessment suggests that the patient is developing an appendicular abscess. And once these parameters are increasing, we are supposed to confirm this with ultrasound, and after doing ultrasound, we are supposed to, very important, do a extra peritoneal. This extra peritoneal is important point. Percutaneous drainage of this abscess. Extra peritoneal percutaneous drainage of this abscess needs to be done. This patient who had a percutaneous drainage done will be offered an interval appendectomy after 6 weeks. Okay, now you tell me, let's see who answers it right. Emergency, okay, no, let me ask in a different. Appendectomy is what type of wound? जल्दी है क्या? नहीं है ना? ऐसा कैसे सेकेंड है? Okay, she is asking किस टाइप की appendectomy? A good question she has asked. Appendectomy हम ज्यादातर किस टाइप की करते हैं? अब मैं एग्जाम में नहीं बताया हुआ, तो अब एग्जामिनर से काउंटर क्वेश्चन तो पूछोगे नहीं, पूछ भी नहीं सकते और बताएगा भी नहीं कोई वहां पर, तो कैसे पता लगाएं आप कौन सी टाइप की अपेंडेक्टमी है ये? अब हमें को सोचना है, हमें को आंसर करना है, तो हमें इस तरह से सोचना है कि कौन सी तरह की अपेंडेक्टमी ज्यादातर होती है, कौन सी तरह की होती है? नहीं, लैप्रोस्कोपिक तो होती है, इमरजेंसी होती है या इलेक्टिव होती है? अब वो बताओ मुझे आंसर। हमने बहुत अच्छे से समझी थी बात। और सोचो, हमें क्या देखना होता है किसी भी वुंड के लिए? एनवायरनमेंट और ऑर्गेनिज्म। अब मुझे बता दो बस, क्लीन, और सोचो क्लीन कैसे होगी यार? व्हाट इज क्लीन? ऑर्गेनिज्म, जीआई ट्रैक्ट खुल रहा है कि नहीं खुल रहा है? तो क्लीन तो हो नहीं सकती। और ओके, लेट मी अगेन रिमाइंड यू, हमें दो चीजें देखनी है, एनवायरनमेंट और ऑर्गेनिज्म। तो क्या पेशेंट एनवायरनमेंट कंट्रोल्ड है? तुमने ये क्यों शुरू किया था? क्यों शुरू किया ये ट्रीटमेंट? क्यों शुरू किया हमने ट्रीटमेंट? क्योंकि एक्यूट इन्फेक्टेड जीआई कंडीशन, और हमने ये भी लिखा अभी तो पेशेंट के एनवायरनमेंट कंट्रोल्ड है? नहीं है। हाँ, तो फिर एनवायरनमेंट कंट्रोल्ड नहीं है, तो ये तो ना तो क्लीन हो सकता है, ना क्लीन कंटैमिनेटेड हो सकता है। तो अब बचा डर्टी और कंटैमिनेटेड। तो क्या इसमें ग्रॉस स्पिलेज हुआ? नहीं हुआ। क्या इस कंटैमिनेटेड वुंड को हमने 4 घंटे तक खुला छोड़ा? तो फिर डर्टी कैसे हो गया? ऐसे मत करो यार। और what type of wound you'll have in a interval appendectomy? जल्दी नहीं, सोचना है। अभी भी 3 है, अभी भी 3 है। Interval appendectomy, what type of wound? ठीक है ना? हाँ हाँ, तो कंटैमिनेटेड तभी तो हुआ। अगर अपेंडिकुलर परफोरेशन हो जाता, अरे तुम परफोरेशन का बोल रहे हो पर एग्जामिनर तो अपेंडिसाइटिस अपेंडिक्टमी का पूछ रहा है। तुम्हारे बोलने से तो आंसर नहीं होगा ना, आंसर तो क्वेश्चन के अकॉर्डिंग होगा। तुम्हारे दिल में क्या चल रहा है उससे एग्जामिनर को बिल्कुल फर्क नहीं पड़ता। इमरजेंसी में परफोरेशन क्यों हो गया? जबरदस्ती है, वो तो कुछ भी सकता है, मर भी सकता है, तो वुंड होगा ही नहीं, बात ही नहीं होगी वुंड। ऐसे तो कुछ भी हो सकता है। Okay, please. Now coming on to, so this is something we should know about appendicitis. Then comes, what is the most common tumor of appendix? And ये मेरी sincere advice है to all of you. तुम लोग दिल से ज्यादा सोचते हो। दिल लगाना ठीक है, बट एग्जाम में दिल से सोचना नहीं है। एग्जाम में जो हमने पढ़ा है उसके अकॉर्डिंग सोचना है। अब अपेंडिसाइटिस की बात हो रही है, अपेंडिकुलर परफोरेशन के बारे में सोच रहा है, ज्यादा नहीं सोचना, सोचने के लिए मोदी है ना। The most common tumor of appendix is carcinoid, and the most common location of the appendicular carcinoid, again a question asked, is tip of appendix. Most common location of appendicular carcinoid is tip of appendix, and the treatment of appendicular carcinoid, again a question asked, is appendectomy. But please be very careful here. Please be very careful here that if in a carcinoid of appendix, which they commonly ask also, if the size of the carcinoid is told more than 2 centimeter, if the size of the carcinoid told in a given question is more than 2 centimeter, or it is told that it is arising from the base of the appendix, or it is told that it is arising from the base of the appendix, or it is told that it is involving mesoappendix, then your answer for appendicular carcinoid should be right hemicolectomy. Then the treatment of carcinoid of appendix will be right hemicolectomy. So these are the things we need to know in appendix. Any question? Can we go ahead?
Yes.
Then comes congenital megacolon, which is also called Hirschsprung disease. What is this condition? In this condition, there is a failure of migration of neural crest cells. देखो एक मेरी बहुत सिंसियर एडवाइस है, मैं जो इतने टाइम से आई एम ऑब्जर्विंग ऑल ऑफ यू इन योर एग्जाम, वेरी कॉमनली यू डू दिस, बट प्लीज रिफ्रेन फ्रॉम डूइंग इट. जो क्वेश्चन नहीं आता ना उसमें सीधे हाथ खड़े नहीं करते, उसमें इंकी पोंकी करके कुछ भी चॉइस को आंसर नहीं करते. यू गाइज आर स्टडिंग. देखो आई हैव टोल्ड यू जस्ट नाउ आल्सो कि यू आंसर, तुम दिल से आंसर करते हो, दिमाग लगाने से पहले दिल से आंसर पहले हो जाता है. You all are studying here. You all are listening to many things. 19 subjects you already have listened, and you will be revising them also. You will be doing a test and discussion also. So many things have gone into your subconscious mind already. तो एग्जाम में जो क्वेश्चन नहीं आता उसमें रेंडमली चॉइस को आंसर करने से बेटर है उसको थोड़ा टाइम लो, उसको पढ़ो. जो आता है वो तो आराम से हो जाएगा, तुम्हें पता ही है, वो कर लोगे. जो क्वेश्चन नहीं आता ना उस क्वेश्चन को कुछ भी नहीं आंसर कर देना, सोचना है, पूरा अपना दिमाग को घुमाना है कहीं, क्योंकि कुछ ना कुछ क्वेश्चन जो भी आएगा वो जो हम डिस्कस कर रहे हैं उसके अराउंड घूम रहा होगा कहीं ना कहीं, और वो तुम्हारे सबकॉन्शियस माइंड में या माइंड के थ्रू गया है कहीं ना कहीं. तो उसको थोड़ा सा दिमाग लगा के फिर आंसर करना है. जल्दबाजी में आंसर नहीं करना. जो क्वेश्चन आता है वो तो आएगा ही, बट जो नहीं आता उसको भी पूरा इज्जत देनी है, रिस्पेक्ट देनी है और फिर आंसर करना है. ऐसे ये रैंडम आंसर नहीं देना. ओके. और क्यों आंसर वो कर रहे हो उसका लॉजिक दिमाग में होना होगा कि इसलिए ये आंसर मैं कर रहा हूं. ठीक है, ये ध्यान रखना भाई. सो congenital megacolon or Hirschsprung disease is failure of migration of neural crest cells. Now, in this condition, what happens is, let's understand this. In this condition, what happens is that some part of the bowel fails to receive ganglion. When a particular part of the bowel fails to receive a ganglion, please understand that particular part of the bowel will not be able to take part in peristalsis, because peristalsis happens because of the sympathetic plexus present in the wall of the bowel. So a particular part of the bowel which has not received ganglion is not going to be peristaltic. So if a particular segment of the bowel is not taking part in peristalsis, this particular segment of the bowel, whichever segment it may be, this particular segment for rest of the bowel will act as a source of obstruction, and because of that the problem sets in a congenital megacolon. Now in this condition, the most common part of the bowel which does not receive ganglion, a very commonly asked question, is rectosigmoid region. The part of the bowel which doesn't receive a ganglion here is rectosigmoid. Now, in this condition, further, this condition can be a short segment disease. This disease can be a long segment disease. Now, what do you mean by short segment and long segment, and what is the difference? In a short segment disease, generally we say short segment when the segment involved is less than 2 centimeters. So in a short segment disease, what happens is a less than 2 centimeter of the rectosigmoid region has not received a ganglion. Okay, so what happens because of that? That particular small segment will be aperistaltic. So this will act as a source of obstruction. But since the segment is so small, the proximal bowel, which has a normal ganglion, with effort, will be able to get past this source of obstruction, and the newborn, this is a congenital problem, so this newborn will pass meconium though, but with difficulty, but delayed, but passes meconium because the proximal bowel, which has a normal ganglion, has a sufficient peristalsis to get past this obstruction. But if the problem is long segment disease, even with a normal ganglion present in the proximal bowel, even with the effort, the proximal bowel will not be able to get past this source of obstruction. So such newborns comes to us with a obstruction. So that means in a Hirschsprung disease, depending on how much segment is involved, can have a delayed passage of meconium, can have a non-passage of meconium also. Those who have a long segment disease will have features of obstruction. That is distension of abdomen, vomiting, and they will be crying inconsolably again. समझ आ रहा है ना? Those who have a short segment disease, who have a delayed passage of meconium, you all know that 90% of the newborns pass their meconium within 24 hours. And then there are 10% who pass late also, 48 hours. So there can be a physiological delay also. So those newborns who have a delayed passage of meconium, most of the time, they are not investigated and they were considered to have a physiological problem and they are sent home. And these newborns, obviously they will grow to a pediatric and then to the adulthood. They will always have this segment which is not taking part in peristalsis. So they will always have a problem in passage of stool now. So they later on will present to the clinician with a complaint of chronic constipation. Now, a pediatric patient, now this is a very important point. A pediatric patient coming to a pediatrician with a constipation is not a new thing, because pediatric patients are, as it is, very choosy about their food habits. So they commonly have a functional constipation also. So how will we know that a pediatric patient who is coming to us with constipation is actually having a functional constipation or having a Hirschsprung disease? So the clinician should be having a high index of suspicion. So how will he clear his suspicion? Now what happens is, imagine this is a rectum. You all know rectum is a reservoir of fecal matter. We know that. So in a functional constipation patient, you will find the rectum loaded with fecal matter. So when a pediatrician should never forget to do a digital rectal examination in any patient coming to them with constipation. Because in a functional constipation, on a digital rectal examination, when a clinician does a digital rectal examination, puts a finger inside, he will get a finger getting soiled with fecal matter. Obviously, the gloved finger. Right? However, in case of a Hirschsprung disease, in Hirschsprung disease, this is a problem. One particular segment of the bowel, rectosigmoid region, is not taking part in peristalsis. So all the fecal loading is going to be there in the proximal bowel, proximal rectum. So when a clinician does a digital rectal examination in such patients who have a constipation, again, their finger will not get soiled with fecal matter. And that doesn't mean now they should put an ungloved finger, they should still put a gloved finger. So finger not getting soiled with fecal matter, very important, is a very important clue to Hirschsprung disease. Finger not getting soiled with fecal matter is a very important clinical clue to Hirschsprung disease. And one should first do barium enema. However, the confirmatory investigation or the investigation of choice, in other words, for Hirschsprung disease is rectal biopsy. It is rectal biopsy, and very, very important point further to note, checked again in our exam, this rectal biopsy should always be taken 2 to 2.5 centimeter above the dentate line. The biopsy of the rectum should be taken 2 to 2.5 centimeter above the dentate line. And what will you get in the biopsy of Hirschsprung disease? Again, important point. In the biopsy of Hirschsprung disease, in the biopsy of a patient of Hirschsprung disease, you will get absent ganglions. Now, just by not getting a ganglion doesn't mean that it's a Hirschsprung disease. The classical finding in the biopsy of Hirschsprung disease, which they already had checked, is absent ganglion with hypertrophy of at least one nerve trunk. If you get this finding in biopsy, then it confirms Hirschsprung disease. Okay, now in treatment of Hirschsprung disease, if it's a short segment disease, in a short segment disease, we will do rectal strip myectomy. In a long segment disease, which most of the time the disease is, in a long segment disease, which most of the time this disease is, we are supposed to do surgery in 2 stages. We are supposed to do surgery in 2 stages. In first stage, you will do a proximal, you will relieve obstruction by doing a proximal colostomy. In first stage, you will do a colostomy to relieve obstruction. In second stage, you will do a definitive surgery, which is also called pull-through operation. And there are various types of pull-through operations. What are the various types? Duhamel pull-through operation, Swenson pull-through operation. These names are important for us. And modified Suarez pull-through operation. Duhamel. And the preferred pull-through operation is Duhamel pull-through operation. So these are the things we need to know in Hirschsprung disease. Then comes क्या हुआ? 2 बार rectal bags. First we do barium enema and then the confirmation happens with the rectal bags. Then comes volvulus. चले आगे. देखो ऐसा है, कर लेते हैं. फंक्शनल कौन सा? क्या करना है जल्दी बोलो. निपटा दो सर. ऐसे मुंह बना रहे हो. अब ठीक है. अगर इंफ्लेमेटरी बाउल डिजीज करनी होती तो वॉल्वस नहीं करते. अगर इंफ्लेमेटरी बाउल डिजीज करनी होती तो वॉल्वस नहीं करते. यू सेड ना कैसा इंफ्लेमेटरी बाउल डिजीज नहीं करानी तो करा दो वॉल्वस करा दो. इंफ्लेमेटरी बाउल डिजीज का मेडिसिनल टॉपिक. वॉल्वस निपटा देते हैं. वॉल्वस. Which part of the bowel, again a question asked, has a maximum risk of rotation? Checked in exam. The part of the bowel which has a maximum risk of rotation is sigmoid colon. The part of the bowel which has a maximum risk of rotation is sigmoid colon. And why sigmoid colon has a maximum risk of rotation? Again a question asked. All of us sitting here has a sigmoid colon, hopefully, right? So our sigmoid colon can rotate. Why should it rotate? First of all, the reason of sigmoid colon to have a rotation, it has a long and narrow. Sigmoid colon has a long and narrow mesentery. Because it has a long and narrow mesentery, there are very high chances of sigmoid colon to get rotation, but this rotation becomes very high if it has a fecal loading. So all of us sitting here has a sigmoid colon, but our sigmoid colon doesn't rotate. Why so? Because the most important predisposing factor for sigmoid colon to rotate is chronic constipation. So any condition which leads to fecal loading of sigmoid colon, any condition which leads to a fecal loading of sigmoid colon can leads to its rotation. So this condition is commonly seen in elderly patients who are bedridden or on antipsychotics or antidepressants. So the profile of the patient can also help us in making a diagnosis of volvulus. An elderly patient who is bedridden, having a chances of chronic constipation, or those who are on antipsychotics or antidepressants, they also have a chances of a chronic constipation. So there can be a risk of volvulus in them. How do these patients present? The most common presentation of a patient of sigmoid volvulus is with features of acute large bowel obstruction. Patient presents with a features of acute large bowel obstruction. What are the features of acute large bowel obstruction? What features are there in an acute large bowel obstruction? फिर दिल से आंसर हुआ, सोचा नहीं पर दिल से आंसर कर दिया. अभी हमने डिस्कस किया है. Patient will have a pain in the flanks, will have a early obstipation, will have a bilio-feculent vomiting, and will have a distension of the flanks. नहीं किया discuss? We just have discussed it. And on examination, you will get a tympanic abdomen with a increased bowel sound initially, and then absent. ये discuss किया. So this patient will come to us with these features itself. Now, what will be the first investigation here? Can you tell me? X-ray abdomen. So in any obstruction, we do X-ray abdomen. And in these patients, the X-ray abdomen is so classical. This X-ray abdomen in these patients is so classical that it is considered as the investigation of choice also. What is the X-ray abdomen finding here? You will get a coffee bean sign or kidney bean sign or bent inner tube sign or omega loop sign or ace of spade sign. These are the various signs which we get. Now, important point to note in this is the coffee bean. This is important. If this is the abdomen, this is right side and this is left side, the fundus of this coffee will be like this. The fundus of this coffee in this coffee bean is like this, pointing towards the right hypochondrium. If you find the fundus of the coffee pointing towards the right side, it is a sigmoid volvulus. It is a sigmoid volvulus. And in patient of sigmoid volvulus, the management depends on, very important, please be careful about it. The management depends on whether the patient has peritonitis or no peritonitis, because these patients can come to us with features of peritonitis also. So, subject to condition, please, patient doesn't have peritonitis. The first line of management, subject to condition, the patient doesn't have peritonitis. The first line of management here is therapeutic, endoscopic decompression. Therapeutic, endoscopic decompression. With the help of colonoscopy, we should try to deflate this distended colon. And very important further to note, after this treatment, if it is successful, please note this because they can ask this question. If this treatment is successful, you should call these patients for elective sigmoid resection. In the elective setting, we should call these patients for sigmoid resection. If it fails, then we are supposed to do surgery. Or if the patient has peritonitis, then also we will directly go ahead with surgery. And in this surgery, this is another important point. This is how the volvulus is. We should not try to derotate this knot. We should not try to derotate this knot. Rather, we should divide this sigmoid colon here. We should divide this sigmoid colon at its base here like this and take out this knot in totality. We should not derotate it. So what we are supposed to do? We are supposed to do emergency sigmoid resection. In this emergency sigmoid resection, we should not do derotation. This is an X-ray, not of sigmoid volvulus. Why? Because the fundus of this coffee bean is not pointing towards the right side. It is pointing towards the left side. And this kind of picture of coffee bean, if you get, this is seen in a cecal volvulus. Okay. So this cecum is also a part of the bowel which can have a rotation after sigmoid colon. More common, they will check you on a sigmoid volvulus, but then they can confuse you with the image of a cecal volvulus. So this is a cecal volvulus, not इसको mirror image कर दोगे तो sigmoid हो जाएगा, right? So this is what we need to know in volvulus. बस करें देखो अब 2 classes बची है. Okay, so we will finish surgery in 2 classes, but then these 2 classes because of my schedule here will be after Diwali. Okay, so we'll meet after Diwali, and please in this time revise whatever we have done in surgery, and then we'll finish up in the 2 classes. Happy Diwali.